Welcome to this video on prone posturing for ARDS. In this video we'll go through the mechanisms of why this particular posture is important for improving gas exchange. So in this video we're going to look at the prone posture. So this is essentially having your patient turned over face down in the particular state of ARDS, which is acute respiratory distress syndrome, which is basically a super inflamed state that your lungs are in. This could be caused by multiple things, but at the moment we're seeing this as a manifestation with COVID-19. Now, it has been known for some time that putting your patient in a prone position whilst being ventilated has a benefit. So over probably 40 years we've known this. However, a particular landmark study in 2013, so a random controlled trial, multi-centered trial, found that if a person is in a severe ARDS state, so they've got severe hypoxia, within that 48-hour window, if you were to put them in a prone posture whilst being ventilated, there is significant benefit. So this has to be run for 14 to 16 hours in that particular position, and they found that if this was done, that the 28-day mortality rate dropped from 32% to 16%, and the 90-day dropped from 41% to 23%. So these are very significant findings, and this was a landmark in the New England Journal of Medicine. So that was a study that has moved to this particular method in an ICU setting. So the mechanisms of why this posture may work come down to these three, which we'll go through. There are potentially additional ones, but these are the three main ones that I was able to find. There is a different distribution in the way that your alveoli are ventilated through your lungs. There is a better coupling, so this is where you match the ventilation of the alveoli to the blood supply. And then finally, there's some additional physiological effects that we'll go through. But before we go through how these work, let's just refresh our knowledge with how the lungs work and how gas exchange occurs. So this is a pretty simple diagram. I'm not a very good drawer compared to Mike. Now, Mike has done a video on ARDS, so if you're not sure of how this works, please watch his video. So what we can see is here is the respiratory tract with the lungs being right and left. What we can see is the trachea comes down and bifurcates into two primary bronchi, and then we have further subdivisions, as we can see. Now, as we move out to the smaller ends of the bronchial tree in the respiratory tract, we have these little circles which denote alveoli, or an alveolus. Now, if you were to count up all this is the area where gas exchange occurs, where we put oxygen into the blood and pull carbon dioxide out to breathe out. At these alveoli level, if you were to count them all up, you're looking at about 300 to 500 million. So it's a huge amount, which is important for gas exchange. So when we have a look at well, actually, with that said, if you were to count the surface area of all these alveoli, comparing a surface area of only 3 centimeters at your tracheal level, by the time you get down to your lung, you're looking at about a surface area of 120 meters squared. So that's getting close to the size of a tennis court. And so that's telling you the importance of having this for increasing the level of gas exchange. So if we were to zoom in at just one alveoli level, and we can see here's the alveolus, okay, and it's in close approximation to a blood vessel. Now, this is drawn to suggest that there's only one blood vessel, but in fact, each alveolus would be wrapped up in approximately 500 to 1,000 blood vessels, which again shows you the extent of the need to be able to have a very close relationship with blood. This is going to be the VQ, the Q being the blood perfusion, the V being the ventilation. A very close relationship so we can put oxygen into the blood and pull carbon dioxide out. Very important process for how the lungs work and keep us alive. Remember, blood is coming from the heart the right ventricle, and it's going to have low oxygen. So this is why I've drawn it in blue. Here we're going to have oxygen jumping in and carbon dioxide jumping out. So by the time we move past the alveolus, and remember there's 500 to 1,000 of these blood vessels per alveolus, we're going to be more red, which suggests more oxygen. And that's going to get taken back to the heart into the left atrium to then be pumped around the body. So this is a critical thing to be aware of in this state of ARDS. Now, this is normal functioning, but when you have a state of acute respiratory distress syndrome, which basically means that the lungs are super inflamed, that means at this level we've got, in the case of COVID-19, a high degree of infection through a virus, which causes a high degree of inflammation, which means out here is like you see in any kind of inflamed tissue. So if you were to hit yourself with a hammer on your finger, after an hour or two, your finger's swollen up. Same thing goes here. You have all this fluid coming out between the lungs, which makes the lungs really heavy, but also it starts to fill up the alveolus with fluid. And that means gas exchange is going to get reduced. Okay, so that's going to cause a problem with gas exchange. Now, if this was to happen in certain regions, that could be compensated by other parts of the lung, but if it starts to diffusely happen through the lungs, then we have problems, and we can go into this state. Now, before we can understand these 2 points of the mechanism of how prone posturing works, so how does alveoli ventilation differ through the lung, and how does the coupling, so the perfusion ventilation, match up, before we can go to the prone state, let's have a look at how it is when we sit upright like so. So let's just focus on this lung. So this would be my side of my lung here. Now I'll get rid of these alveoli here. And what I want to show you is how in your lung at any given time, the size of the alveoli are going to be slightly different. Now if I was to break the lung into 3 kind of zones, like so, an upper, a middle, and a lower. So that would be upper, middle, lower. Now remember, in each lung you've got 150 to 200 million alveoli, but I'm just going to draw one as a representative. Okay. Now your lung is going to be surrounded by pleura. So this is a special wrapping that goes around it. It's a very fine wrapping, which causes it to be in contact with the outside wrapping. So this is the wrapping or the pleura that goes on your chest wall. So there's 2 forms of pleura on each lung. There is the blue one, which is the visceral pleura, and then there's the red one, which is the parietal pleura. The red one is in contact with the inside of your ribs, so the inside of your thoracic cavity. So when you breathe in, that goes out, and this pleural layer, the blue one, which is in contact with the lung, it's connected together, so it's fused together with fluid. And so when this one moves, this gets pulled with it. And so they move together to allow to expand your lung and then collapse back. And that allows you to move air in and out per breath. Now, because your lung is suspended, it's like a big pyramid. It's suspended at the top on the apex, so it's kind of hanging like so. The pressure within this pleural space is going to be much more negative. You know, you're looking at negative 8 millimeters of mercury up here compared to down here, which is much less negative. Still negative. All the pleural cavity will always be negative, but it's going to be much more negative here because it's being suspended and gravity's pushing down. So if you imagine if you had a rubber band or a rubber material and you held it here and you started to pull it down on a weight, the size of, and let's say you on that rubber band you drew a circle, okay? If you stretch that rubber band, what you would find is the greater stretches up here. So that means the size is going to be bigger there, slightly smaller here, and the smallest down here. So that means driven by the gravity, driven by, which then moves to an increase or a more negative number in the pleural space. That means then the size of the alveoli are going to be bigger at the apex of your lung, slightly smaller in the middle lobe of your lung, and then the smallest down here. And what that means, because it's so negative, it means that the lung has to counter this by leaving air within your alveolus. So it's going to actually leave air in the space or in here to counter the greater negative pleural pressure. Okay, so as a result, we actually leave more air in our top part of our lungs, which means we have a residual volume, an increase in air that doesn't actually move. So even though the volume or the size of the alveolus is larger, we're not actually moving air in and out of the lungs so much. But when you compare it to down here, okay, down in the lower lungs, because when you breathe, your diaphragm goes down, that means each time you breathe in, diaphragm down, and breathe out, diaphragm back up, this circle will actually change quite a lot. It'll go from small to big, to small to big, to small to big, to small to big, as you breathe in and out, in and out, in and out, where this one remains pretty much the same. And what that's telling you, each time you go in and out, that's called tidal volume. Not much air is going into here, slightly more here, but the most is happening here. So that means the best ventilated alveoli in an upright position, whether you're standing or sitting, is going to happen in the lower regions. Now, we're going to move now to the prone posture and show you how that changes. But before we do, I just want you to see, what about the perfusion? The same kind of principle arises. Well, you've got your heart in here, and it has to pump blood into the different parts of your lung. And if you imagine a big long tube like so, filled with fluid, okay, to pump fluid right up to this level, you need a great deal more pressure to bring blood into here than you would need to bring into here and then into here. And what that means is you need a greater force, a greater pressure of blood generated from your heart, particularly your right ventricle, to bring blood into here, because it's got much more gravity, more force or hydrostatic force to overcome. So that means this needs greater force, this needs slightly less, and this means it needs the less out of all three. As a result, blood flow into the top part of the lung is the least. This one is slightly more, and this is the best blood flow, which matches actually quite well with the way that the alveoli are ventilated. And that means that you're bringing blood into this part of the lobe quite well to match up with the way that these alveoli are being ventilated. Remember, this is in an upright position, so now we're going to move to prone and see how that changes. So now we put the patient onto the bed. So this is a supine position, so this means the bed's sitting here, so the patient's lying on the bed. The chest is facing up, the abdomen's facing up, the back is down, the buttocks is down. Here we're looking into the patient, so we've cut the patient in half and we're looking in. So behind that in blue is the lung, in front is the red heart, and here is the diaphragm. Spinning the patient over, so here's going to be the bed, so they're lying face down. Here's the buttocks, here's the abdomen, here's the chest, here's the back. Heart sitting in front of the lungs, and again we're looking in. Now if we were to do cuts through, so cross-sectional cuts, we would be looking in. So the ventral is the front surface of the chest, and the dorsal's at the back. Dorsal's at the back now for the prone position, and the ventral's at the front. Now, before we move on, by having your patient in a supine position, so them facing up, what you can actually see is a significant amount of lung tissue. So all the lung tissue here, this is called the dorsal lobes, or the dorsal aspect of the lungs. About 50% is located behind the heart. So only a small amount, about 20%, is located in front of the heart. So that's the first thing to be aware of. Another thing to be aware of is the heart, when you put a person in a supine position, will start to move down and compress this part of the lung. Whereas if you compare it to the prone position, the heart is now moving forward onto the sternum, so there's very little amount of lung tissue that is compressed in that area. Another thing to be aware of is here in the abdomen, so this is going to be all your GIT contents, like your intestines, it's going to press down on the diaphragm like so. And that means this part of the lung tissue here, which we call the dorsal caudal part, is going to be compressed. So that part is going to be compressed down by the heart and the GIT, which is going to make it hard to ventilate that part of it, or those alveoli. Whereas in a prone position, we don't have that issue because all the weight of the abdomen is going more at the front abdominal wall. So that's the immediate changes just by changing the posture. But then let's have a look at the way that the lungs are affected through gravity. Unlike when we stand up or sit up, we don't have gravity acting as forcefully when you lie down. But the way that the lungs are positioned in a supine versus a dorsal aspect, as we saw, 50% of lung tissue is actually found behind the heart, so a lot of it's going to be located there. And it's almost like you're holding a very big spring up by the peak or the apex, if you think of it like a pyramid. And if you had a pyramid shaped spring that's shaped like this and it went bigger at the base, and you could imagine holding it up like that, and your alveoli are suspended through it, what you would see is we have a greater volume here, and it actually gets smaller as we move down. So that means the way that the alveoli will be ventilated in a supine position would be much greater up here than down here. Primarily because the weight of the lung is pushing down and not allowing these to expand for each breath. So that would tell you, particularly if 50% of your lung is located down here, that means a lot of lung tissue in a supine position isn't bringing air in and out. It's only partaking in the top part, which is a problem. Add the weight of the heart, which is coming down even more, which is going to compress that even more and allow less ventilation. And in the state of ARDS, which means the lungs are filled with fluid, the weight of the lung is going to compress this even more, which means the bases of the lung, the dorsal aspect of the lungs, are not going to be very well ventilated, which is not a good thing for gas exchange. However, if you roll them over, the opposite happens. What we now have is this spring is now suspended at the base rather than the apex. And what happens, and this is the main take-home point, is through the whole lung, you've got a much more uniformed alveoli volume, which means that all the alveoli are going to partake in much better ventilation than what we saw in a supine position. Additional to that, the heart is just going to move forward onto the sternum, which is not going to compress any lung tissue, and the GIT is going to go at the front, which is not going to cause any problem. So that's mechanism 1 done. Moving into mechanism 2, which is essentially coupling the VQ. So that's the ventilation with the perfusion. So ideally what we want to do is an alveoli that is well ventilated, which we saw is much more uniform through the prone lung, whereas the best ventilated alveoli is in the ventral portion and poorly at the dorsal portion. We want to bring the right amount of blood to it. Okay, so this is the perfusion. So we want to marry this up almost 1-to-1. Now, it used to be thought that the lung was uniformly supplied by blood. That means the exact amount of blood vessels through the lung would be the same. However, more recently it's been shown that the dorsal aspect of the lung has a greater degree of blood flow, and the way that the blood vessels are arranged, it seems that the size of the blood vessels are larger in the dorsal aspect. Now what that means is if you compare it to here, we had the larger vessels in here, but we had the smallest amount of ventilation. So this would be a very poor matching in a supine position, and that would kind of change as you move up. But when you go prone, we kind of match it really well. Okay, so the matching is uniform to the alveoli ventilation. So in a prone position, we get a tick because we're basically bringing the right amount of blood to the right amount of alveoli ventilation. And that is much better for the gas exchange to be occurring. Now, this leads us into the third mechanism, which is the additional physiological benefits of prone positioning. One of those is it takes the pressure off the heart, particularly the heart that is bringing blood to the lungs. So we have the right ventricle pumping blood to the lungs, okay, through the pulmonary arteries and the capillary bed. Now, if we can match up the VQ closely, that means that the resistance as it moves through the bed of the lungs is a much lower force, or a lot lower pressure, and that means its ability to push through is much more easier. Even in a state of ARDS, so when you have a patient in prone, the pressure on the right ventricle is much less, whereas in supine, because you've got a poor VQ matching, that means the blood vessels that are bigger here and smaller here have to reverse, so this one has to constrict and this one has to dilate, which then causes an increase in pulmonary hypertension or pressure in the vessels, which push back on the right ventricle, which can put the right ventricle under a failure. So you can actually go into a right-sided heart failure in ARDS with a supine position. But when you put them onto prone, because you've got a very good matching of blood to air, there's less hypertension in the pulmonary system, so it takes the pressure off the right ventricle. So that's a beneficial outcome. Now, because the flow of the blood goes through the lungs much more efficiently, that means the blood leaving the lungs and going to the left atrium is going to be improved, so an increase, and that means more blood is coming to the left ventricle, so that the preload's up. That means the efficiency of the whole cardiovascular system is improved when you're in a prone position. Some further benefits is, well, when you're lying down, the way that your body's positioned, you can get more secretions out, at least at the higher respiratory tract, so you can clear your secretions much easier. And because you're ventilating your lungs better in a prone position, you are clearing the fluid out at the lower levels, which we see in ARDS, and the patient is able to get rid of their edema more efficiently in a prone position than in a supine position. So, going back to our objectives, we've seen that the prone position, through the mechanism of distribution of alveoli, we see a more uniform distribution in a prone position than in a supine position. That means a greater amount of lung is going to be ventilated in a prone position than supine, which is going to be beneficial for gas exchange. We saw that in a prone position we have a greater VQ coupling, which means we are matching blood to ventilation much more efficiently in the prone position compared to the supine. And then finally, the additional physiological effects takes the pressure off the right ventricle, gives you a greater preload, therefore your hemodynamic state is improved. We get rid of upper respiratory secretions as well as clearing edema from the lungs. So hopefully now you've seen these are the reasons why a prone position in ARDS when a patient is ventilated can be beneficial.